Hey everybody, Jennifer here. I want to talk to you about cardiac arrest in terms of a timeline. I'm going to set up a timeline on the screen for you in 2-minute intervals. So 2, 4, 6, 8, 10, and 12. Remember that CPR is performed for 2 minutes prior to changing out rescuers in order to ensure the highest quality of CPR is being performed and to improve coronary perfusion pressures. So we meet our patient here at 0 minute. This is whether you've arrived at the patient's side or you've witnessed them go into cardiac arrest. Either way, we start off 0 minute at the moment that we determine that the patient is pulseless and apneic and requires CPR. So we are going to start CPR. Now, what kind of CPR do we do? Well, we do high quality CPR, and we're going to do it for 2 minutes. Setting everything up on this 2-minute cycle gives us a window of 2 minutes in which we can perform our ACLS interventions. So let's think about that. We have to ask ourselves, what can we reasonably accomplish in this 2-minute time frame? Well, the first thing we absolutely have to accomplish is we have to make sure that we have adequate resources. If you're pre-hospital, you're going to summon backup. If you're in the hospital, you're going to press the button on the wall. You're going to get help coming. The second thing that we're going to do is that we are going to apply the patches and get the patient attached to the heart monitor defibrillator so that we can check their rhythm at the end of that 2-minute time frame. It'd be great if we could put in an IV at this time, but we won't necessarily get that done. It requires resources and examining the patient. And if we do have an IV or can get an IV, then it would also be great if we could give an epinephrine. Now I'm going to put epinephrine in brackets so we can come back and talk about it in a little bit. And finally, your instinct might be to say that you would like to perform an endotracheal intubation at this time. I'm going to actually tell you no, that's not indicated at this time. And we'll talk about that more later. Epinephrine and endotracheal intubation we'll talk about more in a minute. Because right now, in 5, 4, 3, 2, 1, 2 minutes have ended. At the end of the 2-minute time frame, we need to do a pulse check, we need to do a rhythm check, and if it's still VFib or pulseless VTach, we need to shock our patient. Now at this time, we don't care if their rhythm changes, and we don't care if they get pulses back. We're just going to launch right back into CPR. And of course, that's high quality CPR. And this gives us our second window of time. So now we have to ask ourselves, what can we reasonably accomplish in this second window? Well, if we didn't get the IV initially, now is the time to get our IV in place. And if we did get the IV the first time, we're going to follow it up with a second IV. We always want to celebrate our first IV by getting a second IV. And a medication is indicated here. Remember that the American Heart Association likes us to go for drug, shock. So we're going to continue in that process. So which drug or which medication is indicated right now? And the answer is amiodarone. Now we'll talk about amiodarone a little bit more in just a moment, but it's not time right now. We also might be considering doing an endotracheal intubation at this point. That could be your instinct, but we're going to put that off right now as well, because in 5, 4, 3, 2, 1, 2 minutes have ended. At the end of 2 minutes, of course, we're going to do a pulse check, we're going to do a rhythm check, and if it's still pulseless VTach or VFib, we're going to defibrillate, and then we're going to launch right back into high quality CPR, creating our next window of time. And now it's time to ask ourselves, what can we reasonably accomplish in this window of time? Well, if you haven't gotten your first IV or your second IV, now's the time to do it. And now let's talk about epinephrine. I'm going to take it out of those little brackets. Okay, so let's talk about epinephrine. Well, epinephrine is indicated every 3 to 5 minutes. So it's time to give an epinephrine in this window. It's important to know that epinephrine is dosed as 1 milligram every 3 to 5 minutes. And epinephrine doesn't have an ending point in the setting of cardiac arrest. So epinephrine is just going to continue every 3 to 5 minutes until the end of this cardiac arrest. little arrow right there. You can see we gave our first epinephrine right around here at the 1 minute mark. Our second epinephrine's coming in between 4 and 6, right around the 5 minute mark, between the 8 and 10 around the 9 minute mark, and so on. So all you have to do is remember that it's drug, shock, and epinephrine is in every other window. And epinephrine just goes. And epinephrine's just about the only thing we have to accomplish in this time frame. But 5, 4, 3, 2, 1, 2 minutes have ended. Time for a pulse check, time for a rhythm check, and time to defibrillate if it's indicated. And then we're going to launch right back into our high quality CPR. And that brings us to our next 2 minute window. So what can we reasonably accomplish in this 2 minute window? Well, let's stick with the medications for a moment. Let's get back to that amiodarone. So amiodarone is indicated now in this 2 minute window. Amiodarone is administered, let me make that little line there. Amiodarone is administered with the initial dose at 300 milligrams, followed by 150 milligrams, but only one time. We actually run out of amiodarone after 2 doses. So the epinephrine continues all the way through, but the amiodarone ends right here. Okay. You're probably thinking I'm going to count down and say 5, 4, 3, 2, and so on, but I'm not going to, because right now I'd like to discuss endotracheal intubation. Now, your instinct might have been to call for endotracheal intubation in the first 2 minute time frame, or even to call for it in the second 2 minute time frame, but it's not indicated there unless, and this is really important, this is a limitation to this 2 minute time frame. Endotracheal intubation isn't called for until after the second window, somewhere between the 4 and 6 minute mark, unless there is ventilatory failure. This is so important, I think I'm going to put some exclamation points next to it. So a limitation of this 2 minute time frame is if there's ventilatory failure. If you cannot ventilate your patient from the beginning, then you need to intubate the patient. If you can't ventilate your patient later in the arrest, you need to immediately intubate your patient. But ultimately, if you're able to ventilate your patient, then endotracheal intubation isn't really indicated until somewhere between the 4 and 8 minute mark, or right around that 6 minute pause for pulse check and rhythm check. And let me tell you why. Many studies have shown that a person in cardiac arrest, a VFib arrest with a short downtime, will come back in this 0 to 2 minute mark with the initial defibrillation, so right around here. Or they'll come back in this 2 to 4 minute mark after they've received epinephrine and defibrillation. We'll get them back early. So intubating at that time isn't indicated. In addition to that, intubation is an interruption to CPR, and we don't want to interrupt CPR at all because we need to improve coronary perfusion pressures. So, intubation is going to come in at this interval here, and intubation gets us a couple things. First of all, we get to do end-tidal CO2 monitoring, and end-tidal CO2 monitoring tells us about how good our CPR is. In addition to that, endotracheal intubation at this interval allows us to perform compressions asynchronously with ventilations. I'm not going to spell it asynchronous. I can't at this level right here. Okay, compressions can just go. We don't need to pause for ventilations. So endotracheal intubation, absolutely indicated somewhere in this 4 to 8 minute window. Not the best plan at the 0 to 2 and not the best plan at the 2 to 4. But the big limitation here is if there's ventilatory failure, you need to put in an airway at the soonest possible opportunity. All right, so let's move on. In 5, 4, 3, 2, 1, stop CPR. We're going to do our pulse check. We're going to do our rhythm check, and we're going to defibrillate if a defibrillation is indicated. And then we don't care if they have a pulse. We don't care if their rhythm comes back. We just immediately launch into high-quality CPR, and that puts us into our next window of time. We already know that epinephrine is indicated in this window. And naturally, if we haven't hit on any of the key points earlier, we absolutely need to hit on them now. But there's one key point, there's one item that we haven't discussed, and I want to bring it up now, and that is the H's and T's. Remember that the H's and T's are part of the differential diagnosis for what caused the person to go into cardiac arrest. We think of it in PEA and asystole, but we need to think of it in all the situations, PEA, asystole, and also in VFib. From now on, it's important to remember that the H's and T's start at the beginning of your cardiac arrest and go all the way to the end of your cardiac arrest. You always want to be thinking about the H's and T's. For example, if your patient is in the hospital and ventilator dependent, and they go into cardiac arrest that presents in ventricular fibrillation, the most likely cause of ventricular fibrillation in those early moments is going to be some sort of respiratory compromise related to the ventilator or the ventilator settings. So if you don't think about the H's and T's, if you don't consider that ventilator, then you're not going to get that patient back until you correct that problem. So ventricular fibrillation, not likely to be caused by these things as a presenting thing, but it's possible. You should be thinking about it the whole time. Similarly, for a trauma patient, they may present in ventricular fibrillation because of a traumatic blow to the heart and end up hemorrhaging heavily. And if you don't think about that until the person actually lapses into a PEA, then you're missing out on the opportunity to repair the problem early. So please don't forget, the H's and T's start at the beginning and go all the way through to the cardiac arrest's end. Always be thinking about the H's and T's. I'm just going to clean this up a little bit so I have some room to write. Okay, so H's and T's continue. Perfect. And right now we're going to go to 5, 4, 3, 2, 1. 2 minutes have ended. If we haven't, we need to get to a pulse check, we need to get to a rhythm check, we need to defibrillate if a defibrillation is indicated. And at this moment, we notice that although we're supposed to go drug shock, we've run out of amiodarone and epinephrine is not indicated right now. Well, a secondary antidysrhythmic is indicated at this juncture. And so that might be lidocaine, it might be magnesium, and it might be procainamide. Now, if you're old school, you've probably given these medications because they were what we had prior to getting amiodarone. But it's not mentioned in the ACLS algorithm. There's limited space on those pages for the algorithm. But these medications are mentioned in the formulary. So remember, as you're in this window of high quality CPR and you're trying to figure out which medication is indicated, if an antidysrhythmic is indicated, you might need to know lidocaine or magnesium or procainamide. So be prepared with plenty of assistance to help you look up which medication is appropriate. So there you have it. Embracing the 2-minute timeline, I promise, will help you slow down time. Not interrupting CPR will help you improve cardiac save rates. And finally, I think it's a great way to organize things. Thanks for listening.